Before I get started. Nope, okay. I take silence as yes. All right, before we actually go to this slide, there was one more slide on the previous page where I did not talk about risk factors. I'm just going to hit those real quickly. Understand those risk factors are for all three of the COPDs that we're going to talk about. Okay, so this first one is smoking, and so smoking stimulates excess mucus production. It decreases the ciliary function, so the things that get trapped in the mucus, in effect, stay stagnated there in the lungs. They don't move toward the back of the throat where we can cough them or we can
It's the bottom slide on
swallow
page
them.
131.
And then the third one is it triggers
Yeah, he's saying.
release of an increased amount of proteases, and we'll talk about that more in detail, I think, here in just a moment. Yes, that slide. Yeah, the slide is the correct one.
Page 131, the bottom
I
one.
think it is, I don't know.
We
I'm
don't
so
have
confused right now. Hold on.
slides.
We'll
I
move
have
to the
it.
next slide and we'll see if it changes. I don't know.
Yeah.
I know.
Actually, I know it does. Hold on.
So the first one is stimulates excess
This was
mucus.
where we went last week.
But he was asking if we
Here
had
we
the
go.
correct
Now we're
slide,
there. Thank
which
you.
we did not.
All right. So,
Oh, for seeing
stimulates
it.
excess mucus production. See, I'm a little rattled, and I apologize, but we will get through this. But I may be talking a little faster than I would prefer, and I apologize for that as well. Boy, I'm an apology expert these days, am I not? All right. The ciliary function.
Mr. Baird, I'm sorry to bother you. Taco wants to make sure your lecture capture's on, just because today started out strange and I know you have to talk fast.
Well, thank you very much, Tonkwall, because no, of course I am. All right.
Thank you for checking.
Thank you for checking. Do you guys want to really know something funny? I'll probably have to apologize for this too, but I'm going to tell you all anyways, because this is the day I'm having, all right? I helped Mrs. Crouch in Skills Lab, and then I went back to my office to take care of some things. And I'm sitting in my office just catching up on the emails, all the emails that people have sent me since Tuesday, okay, so as I explained for yesterday. I'm sitting there, and all of a sudden I glance at the time on my computer, and I realize 12:26 p.m. How can that say 12:26 p.m.? All of a sudden I realize, what? I've got 4 minutes to be to class, and I haven't gone to the bathroom in several hours. So whilst I'm standing here in front of you, I'm about to wet my pants. Right? So when I come in here a few minutes ago and the whole computer thing messed up, I spent 20 minutes trying to get the computer to work while I'm still needing to go. And it's like, I could have gone. Anyways, that was free information. Oh no, and that's on lecture capture now. I am having a day. All right, so that's right. I'm testing the waters. Testing the waters here. All right, here we go. Risk factors for all of the COPDs. Smoking is the big one that we talk about the most. We'll look at it in more detail, especially with emphysema, but it affects all three of those. Stimulates excess mucus production, decreases ciliary function. So basically, when you inhale something and it gets trapped in that mucus, the mucus doesn't have an easy way to get out of the lungs. And so it accumulates and it pools in the base of the lungs. Smoking also, because of the tremendous amount of allergens that are contained in that smoke, trigger the release of an increased amount of proteases. Proteases are enzymes that your lung produces to eliminate proteins that you inhale. So remember, an allergen is most often a protein. Okay, so bacteria and viruses, they are proteins. So whether it's an allergen or a protein or a virus or a bacteria you inhale, the proteases help eliminate that. So we'll tell you how smoking interferes with that in a little bit. Okay? All right. And then the last one, smoking inflames and damages the actual tissue itself, both in the bronchioles, so the little airways, as well as the alveoli walls, the alveolar walls. The next risk factor is chronic respiratory infections. So someone who has repeated infections is at risk for developing the COPD package, if you will. And then the third one we mentioned briefly was heredity and genetic predisposition. Specifically, we're going to talk about that in the context of AAT deficiency, okay, alpha antitrypsin factor. AAT, capital, all three capital letters, is a genetic predisposition specifically for emphysema. All right, I believe we're ready to actually get past this slide. All right, so as I mentioned on Tuesday, I set up your slides differently on this lecture. One of the things I emphasized this year in boot camp that I haven't as much before is the whole idea of comparison and contrast. It helps you to understand things on a deeper level if you recognize things that are similar between substance and things that are different. We call that comparison and contrast. So instead of telling you everything about bronchitis and then going on to emphysema and then going on to asthma, I'm telling you everything about each of these simultaneously on, for the most part, the same page, so that you can compare apples to oranges to bananas and recognize they're all still fruit, okay? So chronic bronchitis, the underlying pathophysiology is there is an increase in mucus production. It's a result of chronic inflammation of the bronchi that leads to an increased size and number of those submucosal glands that line the airway that I mentioned on Tuesday. Remember, they produce that mucus bed or that mucus blanket that lines your airway, as do the goblet cells, which also increase in number. So because of that chronic inflammation, then you have chronic increase of mucus production. But then you also have the ciliary function that just can't handle that kind of volume of mucus. And so that it can't clear it. You're overworking those little hairs. And so it pools instead of clears, leading to an obstructed airway, especially the smaller airways. And then what happens is the mucus is thick and viscous, causing those smaller airways to collapse, leaving the alveoli with trapped air. Well, that trapped air is still going to diffuse. So the oxygen that's in that alveoli is still going to go into the bloodstream, and CO2 is still going to go in there, but then it's stuck. They can't get rid of it. Nor can they refill that alveoli with oxygen. And we call that air trapping. So in effect, it decreases the body's ability to ventilate those alveoli that are now have mucus plugs or they have collapsed airways. As a result, what happens in the blood? You have less oxygen in the blood and more carbon dioxide that accumulates over time. Well, your body still needs the same amount of oxygen, and so it thinks that maybe we just don't have enough red blood cells to carry oxygen with. Maybe that's why we're not getting what we're asking for. And so it sends messages to your bone marrow and to your, oh my goodness, sorry about that, your spleen, and it starts dumping those red blood cells into your bloodstream, giving you what we call polycythemia, or poly meaning many, and cythemia meaning cells within the bloodstream, specifically too many red blood cells. Okay, so literally the blood is thicker with these extra red blood cells than it should be. Emphysema, the primary pathophysiology is the alveolar walls have been damaged. And they've been damaged, we believe, by the body's enzymes, specifically those proteases that I talked about. Remember we said the proteases are what digests or breaks down those proteins that you have inhaled. Well, what is your lung tissue made out of? Protein. So it would make sense that the protease could start digesting the lungs unless we had somebody to say, whoa, 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 that's enough. Stop eating and move away from the banquet table, okay? And we do. And that's what AAT is. Alpha antitrypsin factor is the barrier, if you will, the chemical that prevents the proteases from digesting your lungs. But when a person has an increase in protease production, it doesn't have the counterpart. It doesn't have the counterpart of more AAT. And so the excess proteases make it to the banquet table anyways. And they begin to damage those alveolar walls. So what ends up happening is some of those smaller airways begin to collapse. You lose that elastic recoil that helps the person exhale, because remember, that's a passive process. And then the alveoli begin to form large, floppy sacs called bullae. Those large floppy sacs are when 3 or 4 little bitty alveoli, because of the damage being done, fuse together as one big lumpy alveoli. Now, that might sound like, well, they should be able to breathe better, but no. What happens when you move from 3 small things to one big thing is you lose surface area. And surface area is what allows gas exchange to occur. So what ends up happening is they have less surface area to promote oxygen and carbon dioxide exchange. It leads to a portion of their lungs being unable to exhale effectively. We call that dead space. And it leads to the alveoli remaining over distended. Much like the air-trapped alveoli that we have in bronchitis, they're not as effective. So 2 different pathophysiologies, but the same end result is that alveoli cannot do their job effectively, and gas exchange is impaired. Asthma. Asthma, just like chronic bronchitis, involves a chronic inflammatory process in response to things the person is inhaling. It typically occurs in 2 phases, so there's an immediate occurrence, and then a delayed response that happens as a result of some chemical mediators being released. Those chemical mediators being things like leukotriene, for example. When those things occur, we have an increase of swelling within that mucus layer of the airway. We have increased mucus secretion trying to trap any other allergens from getting down into our lungs, because our body says, this is not me, I don't want it here. And then airway inflammation increases across all the tissue, if you will, of that airway. Okay? So it's not just where the allergen first touched, it's now spreading. Leads to the airway responding both through inflammation and bronchoconstriction. So asthma includes both components. And so there's a self-sustaining cycle of inflammation and bronchoconstriction or obstruction to airflow. And so the airway can respond not just to allergens or antigens, but there are other stimuli that can produce this same response for a person suffering from asthma. So intense emotion, temperature extremes can induce an asthma attack. Exercise, so an increased demand or a challenge to the respiratory system can also stimulate an asthma attack. All right, any questions about patho, or how those are similar or how those are different? Okay? So let's talk about what we see as nurses when they come to us. What do we see whenever they show up and they're having trouble breathing? First off, I want to tell you that sometimes we use the nickname for somebody with chronic bronchitis as a blue bloater. Blue bloater. People with chronic bronchitis have a productive cough, and they produce copious amounts of very thick, tenacious sputum. They have a decrease in exercise tolerance, so as the disease progresses, they become less and less active because they can't breathe if they are active. If we auscultate, we often hear wheezing. Remember, wheezing is narrowing of those smaller airways. Bronchi is narrowing of the larger airways. They are short of breath, sometimes to the degree, depending on how progressed they are, where they cannot even talk without pausing in the middle of a sentence to catch their breath. They can't eat without pausing in the middle of chewing and swallowing. They have what we call a prolonged expiration. In other words, they're trying to exhale, but it's now an active process. They're trying to overcome that resistance to airflow. We already mentioned they have chronic hypoxemia and chronic hypercapnia. Tonkawa, what was hypercapnia again? Yeah, so too much carbon dioxide in the bloodstream. And hypoxemia, Enid, was what?
Too little oxygen.
Too low of oxygen in the bloodstream.
Little oxygen in the bloodstream. And still water, what is hypoxia? Too little oxygen in the tissues. Very good. Make sure you understand those three terms because the symptoms a person presents with all three of those can look very similar, but the way we treat them as nurses is very different. All right? All right, so because of that hypercapnia and hypoxemia, they often have a cyanosis color. So that's where we get the nickname, the blue bloater, is they have that increased anterior-posterior diameter. What's another name for that, Tonkawa? Barrel chest, very good. By barrel chest, what we are talking about is if you look at a person who does not have COPD, if you look at how thick they are from front to back in ratio to how thick they are from side to side, they are approximately one thickness, and if you put 1.5 of their thickness this direction, they're roughly 1.5 wide, so it's a 1 to 1.5 wide ratio. Somebody who has a barrel chest, they are typically as thick front to back as they are wide. So they look like one of those old-fashioned whiskey barrels or the things you see in the cartoons where Wile E. Coyote went over the waterfall. It must have been 1,000 times in one of those things. Okay? And I hope you're not too young to know who Wile E. Coyote is. All right. Emphysema. Don't tell me if you are. Don't tell me if you are. All right. Emphysema. Signs and symptoms there. They have a progressive dyspnea on exertion until their disease reaches a point where they're dyspneic even at rest. They can't even sit or lie down without being short of breath. They often breathe faster, but it's more like a panting breath. Their breath is not very deep, although it is very labored. And the reason is that when we take a chest x-ray, because of the changes in the alveoli and the inability to, with that lack of elastic recoil, they can't exhale fully, then air stays behind and overinflates the lungs, and it pushes our diaphragm, that muscle that helps us be able to ventilate in the first place, it pushes it down. So they don't have a much extra chest cavity potential, if you will, to take their next breath. So every breath they take has a smaller tidal volume, and they have to breathe more often to get the same amount of benefit. So what do we hear because of that overdistension? Remember, breath sounds, the only way we hear breath sounds is air has to be moving in and out. Lungs do not have sounds. Okay? We don't have lung sounds, we have breath sounds. Okay? If a person's not breathing, you hear nothing. So when we say decreased breath sounds, that is related to the fact that breath is not moving in portions of their lungs because of that increase in dead space we talked about just a moment ago. Their fingers, and there's an excellent picture of that in your textbook, and I don't remember if I wrote it down for you. Hold on if I did. No, I don't think I did, but for this edition. So there is a picture of that, and I believe it's in the second set of page numbers. So I think it's in
576.
563 to 581 section. The clubbing of
566.
fingers represents chronic hypoxemia. And if you look at their finger, it literally looks like the tip of their finger is pointed or tipped, if you will, downward towards the palm of their hand. It begins to curl downward, if you will. And that's that clubbing of fingers or clubbing of the fingernails. They use their accessory muscles. So they use those other muscles like their abdominal muscles, their neck muscles, their subclavian muscles. They use anything they can to try to make their chest bigger so they can ventilate. And so we often see retractions in that context. These people, however, are not typically blue, they are typically pink like anybody else. And so we call them pink puffers because their breasts are so small that they're staying pink. So they can get oxygen down into their lungs, they just can't get it back out, the CO2, as easily.
Pink.
And they also have an increase in AP diameter, but for these people, it's often more dramatic than those with chronic bronchitis. Okay, it's much more pronounced. Asthma, how do we see that? They too have dyspnea, but it typically is intermittent. So in between what we refer to as an asthma attack, their level of functioning respiratory-wise may look very normal to someone. Okay, that you might not be able to look at your neighbor and say that person has asthma when they are stable in their condition. So that's how asthma is different than the other two. It's an intermittent but chronic condition. But when they are experiencing exposure to an allergen or a stimuli that's causing airway constriction and airway inflammation, they will be dyspneic just like the other two. They will have marked respiratory effort, often showing up as nasal flaring, meaning that when you look at their nares, when they attempt to take a breath, they work so hard that they open wider, that's nasal flaring. They use pursed lip breathing, and they also use those accessory muscles. The primary sound we hear is the smaller airways being constricted, and that is wheezing. However, when an asthma attack progresses to the point where you heard wheezing a few minutes ago, and now you don't, that's an ominous sign. That means the airway is fully constricted, closed. There's no airflow in and out of those alveoli anymore. And that person is about to die of it. Okay? Bronchospasm, as a result of trying to clear that airway, trying to open up a narrowed airway, our body responds by trying to open that up by coughing one cough almost after another. You might call him, instead of a chain smoker, a chain cougher during that moment in time. That too is a very adverse sign to see. And we're going to talk a little bit about what that sentence right there means, but those are pulmonary function tests. And basically it means that the person cannot exhale effectively. The amount of air that they normally could blow out of their lungs with exhalation has now decreased. Okay, that's what those two in effect mean. What does that mean in a nutshell? It means that that patient will often have a compromised O2 sat. So is that hypoxia or is that hypoxemia? Stillwater? Decreased O2 sat, is that hypoxemia or hypoxia?
Hypoxia.
Hypoxemia, good. Okay, and so is a decrease in partial pressure of oxygen. These are blood gas numbers here. And then an increase in carbon dioxide. Okay? Now, when you look at those three lists, if you look at them side by side, it's like, well, those are kind of hard to tell apart, right? Okay, so I want you to go back and put an asterisk by what I would consider the key signs and symptoms for each one. So go back up to chronic bronchitis and put an asterisk next to a productive cough of copious sputum. Second one, wheezing or bronchi. And then the third one is cyanosis. The four that I want you to mark for emphysema is a decrease in breath sounds, clubbing of the fingers, they're generally pink, and that dramatic barrel chest. Asthma, I want you to recognize that in between there's not any symptoms that might even be noticeable, but when they are, they have dyspnea and marked respiratory effort with wheezing. Okay? All right, so regardless of which of the COPDs we're dealing with, they all have the potential for some of the same complications. So I'm just going to touch base with you as far as what each of those are. All right, the first one is respiratory infections. Remember, our bacteria in our world loves to live in a warm, moist, nutritious place. And that's what your lungs become, or that's what this patient's lungs become when they have excess sputum production and the inability to clear it. Okay, they got plenty of nutrition in that sputum, plenty of moisture, plenty of warmth, and plenty of darkness. Respiratory failure. Remember how I showed you on the continuum. Respiratory failure does not mean the same as respiratory arrest. Remember the difference? Respiratory failure means the patient cannot meet their gas exchange needs and then not be able to maintain their acid-base balance. Those are the two key components of respiratory failure. It does not mean they're not breathing. That's respiratory arrest. They cannot meet their gas exchange needs, so they can't get enough oxygen in or enough carbon dioxide out, or they can't maintain their blood gas or their acid-base balance. Okay? Pneumothorax. Pneumothorax, in effect, simply means a hole in the lung tissue that allows the air that normally is inside the lungs to go out into the pleural cavity and begin to compress the lung tissue itself. We call that a pneumothorax. Unfortunately, because of the volume of coughing and because of the poor nutritional state for these people, many times they develop what we call a spontaneous pneumo. So they literally cough hard enough that they blow a hole in their lung and it begins to collapse. Okay? As opposed to somebody who has a pneumothorax because they were in a car accident and slammed into a steering wheel. That's a different kind of pneumothorax. And you'll learn about a different thing called a hemothorax in adult too. But pneumo is what we see in this context. The fourth complication is status asthmaticus. Status asthmaticus is when that asthma attack has progressed to the point that it is now life-threatening. That's when that ominous sign, you might not hear any breath sounds at all for one part of your lungs. In fact, you might think they've had a pneumo, but that's not as common with asthma as it is with bronchitis and emphysema. It's most common, pneumothorax is most common with emphysema. That's spontaneous pneumo. Okay? But status asthmaticus is very serious and it is a life-threatening emergency. And then the last complication on there is something we call cor pulmonale. And cor pulmonale, I think, is mentioned in this text, unless I don't remember if this is this year's or not. I think it's 558 and 559 if this is the right edition. But basically, it is right-sided heart failure that results because of the changes, the anatomical changes in the lungs, makes it harder for the blood to flow through them, through the alveoli of the lungs. And so that increased resistance makes the right side of the heart work harder. And so it enlarges to compensate, but eventually it develops a form of heart failure. So when that heart failure is due to a respiratory problem, such as emphysema or chronic bronchitis, we call that cor pulmonale. All right. All of these diagnostics and labs I have discussed and explained in detail out on Blackboard in order that we use our time in class effectively. Don't hesitate if you watch that video and pull up that handout. If it does not make sense, then post something on the discussion board and I'll try to clarify it for you. Okay? Main thing I want you to know is these are the primary ways that a licensed provider determines the nature of the patient's condition and whether or not they're dealing with an acute problem, like we're going to talk about later, pneumonia, for example, on top of their chronic problem. Okay? So, pharmacology of drugs. Give me just a second. I might get that bathroom break before we go here. Hold on just a second. Now, let's see if we can talk through these real quick. Since we got such a late start, maybe I can hold your attention for a few more minutes. All right? So, when we're talking about meds, I want you to understand that oxygen is a medication. Yes, it is a gas, but it is a medication that we have to provide according to a provider's prescription. Okay, so it is a dependent intervention, dependent action, just like all these other meds. Oxygen is used to relieve hypoxemia, with the intent that if we get enough oxygen in their bloodstream, then we'll also address any hypoxia they're experiencing as well. However, we need to use it cautiously in a patient who has COPD, specifically emphysema or chronic bronchitis. Sometimes those people's disease has progressed to the point where their respiratory drive is now prompted by low oxygen levels. I think we're back to Enid. Enid, what did I say on Tuesday our normal, healthy respiratory drive responds to? What makes a healthy person breathe faster and deeper?
Exertion. Yeah.
A challenge. They said exercise?
And that can bring about this change, but we talked about how the respiratory center has chemoreceptors and it's looking for something all the time. And when it sees an increase in this, it responds by breathing faster and deeper to fix it.
Oh,
What was
CO2?
that?
CO2.
CO2?
That's correct. So when we look at this, when we have to understand that somebody who has chronically high carbon dioxide levels because of their emphysema or their chronic bronchitis, it confuses the respiratory drive, and eventually it says, no matter what I try, I can't breathe fast enough or deep enough to get rid of this stuff. And so it gives up trying. It begins to respond then to low oxygen levels. So when you give somebody who's breathing 28, 30 breaths a minute and has a chronically high CO2 level because of their COPD, and you give them oxygen, and all of a sudden now you're meeting their oxygen need greater than they're used to, their respiratory drive says, I don't have to breathe this fast or this deep anymore. So when they start to breathe slower because their oxygen need is now being met very easily with that extra oxygen, what happens to their carbon dioxide levels? They increase because they were needing to breathe that fast originally to get rid of carbon dioxide, not just to get oxygen in. So what happens with these people is not the oxygen so much that's hurting them, it's the accumulation of more carbon dioxide because they're going to breathe slower if we give them more oxygen than is necessary. So we treat their hypoxemia more conservatively. So that's why sometimes freshman students struggle with what's a normal pulse ox. Because those of you who work as a nurse aide, you might see somebody who has a pulse ox that's 90 to 92%, but the doctor doesn't order oxygen. And you've been learning that 95 to 100 is normal. Well, if you put a patient with COPD whose respiratory drive has flipped, if you push their oxygen level up to 95% or more, they will slow down their breathing. Many of them will. Not 100%. It's not predictable. So we treat it more cautiously. So most of the time, a physician doesn't apply oxygen for these clients unless they drop below 88% or unless they are symptomatic with that. Okay? So they're confused, disoriented, etc. And we'll talk about some other options to address that problem called BiPAP and CPAP later in our lecture. So it's not uncommon when these people do need oxygen that we limit it to 2 to 4 liters by nasal cannula. We can use a Venturi mask if they need higher oxygen concentration, but the reason we use a Venturi mask is it does not promote CO2 retention like a simple mask can do. It's not intended that a simple mask do it, but it can still do it. If a client is a mouth breather and they begin to fall asleep and you're having trouble meeting their oxygen need, you can slip the nasal cannula down in their mouth and it's still considered acceptable. Okay? So if they sleep with their mouth open and most of their airflow is in and out of their mouth, then you can address it that way. Pursed lip breathing promotes gas exchange by prolonging expiration. Okay? So it gives time for that gas exchange to occur, helping their ventilation. So we have to teach them pursed lip breathing. The next drug class, remember in the fall I talked about how there were different types of bronchodilators? So these next 3 slides are 3 of the main types I want you to learn about. Beta agonist or beta 2 agonist stimulate the beta 2 receptors in the lungs. And they may also play a factor in enhancing mucus clearance. So it might help get some of that out. Basically, when you stimulate those beta 2 receptors, it causes bronchodilation. It allows their airway to enlarge to allow more air to get in and out of those lungs. There are inhaled forms, there are parenteral or IV forms, and there are oral forms. They typically have a rapid onset and they peak in about 60 to 90 minutes and they last for 3 to 4 hours. I've listed several of the common ones you may have already had patients in clinicals who have received these. Okay? Notice how beta medications end with the OLs. Okay? So it's a way to remember that drug class. Common side effects for most of these include tachycardia or some form of palpitation, tremors, nervousness, and sometimes they feel nauseated as a result. The anticholinergic agents, they have a greater bronchodilated effect and fewer side effects than the beta agonists, and they work by working on the opposite side of the sympathetic nervous system. So if we can block the cholinergic receptors, then we can cause airway dilation in those larger airways. The anticholinergic agents are primarily the inhaled form, but notice how they peak a little bit later, and so their onset is longer. I mean, it takes longer for them to start to work. They peak a little bit later, but they also last longer. So many times what you may have already seen in clinical is we have combination meds that have a beta agonist in it as well as an anticholinergic agent. So it will kick in fast and last longer. And we call the most common one Pneumonia. Okay?
What do you say?
So examples of anticholinergic agents are ipratropium bromide and atropine. I'm on your account. So I'm spending every extra cent you have out of your bank account. Yeah. I'll talk to you in a little bit. Oh no, I did, didn't I? I did just lecture capture that. Oh man, I've got 2 things to incriminate now. All right, so side effects of the anticholinergic agents are just like the oral anticholinergic agents. Blurred vision, dry mouth, urinary retention, constipation, as well as sometimes people develop a cough. They may taste a bitter taste in their mouth, and they may even feel dizzy or a headache. The third drug class of bronchodilators is not used as often as it used to be used, and it is primarily because there's such a narrow margin of safety with them. However, there are certain clients with COPD that benefit tremendously from their use, and so they're still out there. The methylxanthines also produce bronchodilation. They do enhance clearance of that mucus from the airway, but they do it by stimulating the central respiratory system. In other words, they dilate the blood vessels within our lungs. So they decrease resistance to blood flow from the heart, making it so their lungs actually work better even while they sleep. Remember how we said that normal exhalation is a passive process, but we said chronic bronchitis patients, emphysema patients, and even an asthma patient during an asthma attack all have a forced expiration. They cannot get rid of the surplus air in their lungs. And so it creates that sense of air hunger, that shortness of breath, that dyspnea, and they are afraid to go to sleep. If I fall asleep and I don't keep working, I will die. Well, guess what? There's an element of truth to that. Okay, so when we give them a methylxanthine, then that helps promote their breathing so they can relax well enough that they can sleep and then not change their respiratory status. There are oral and IV agents as well. But because there's such a narrow margin of safety, we have to monitor the blood levels of these drugs. Okay, and give me just a second, I'll give you the therapeutic range that we want you to go with, or I want you to go with for the test, is 5 to 20 micrograms per milliliter. 5 to 20 micrograms per milliliter. And you might see some sources that will say 10 to 20 milligrams is considered therapeutic. Remember, we said that's true for almost every lab value out there. But the ones that will apply to my test questions are 5 to 20. Okay? Micrograms per milliliter. Examples of those are theophylline and aminophylline. And then these are their side effects. Notice how tachycardia, tremors, nervousness, there's an overlap between all three of the bronchodilator classes. Gastric and GI symptoms sometimes suggest that the patient's getting too much of their methylxanthine and we need to check a blood value. Okay? Now, interestingly enough, this particular drug class is very similar to caffeine in chemical structure. And so a person who drinks a lot of coffee, tea, cola, or chocolate, eat a lot of chocolate, I guess you could drink chocolate too, I guess, can very easily change their blood values of this number. They are so chemically similar. But that's also why you see a lot of the chronic COPD people, they can't start their day without some caffeine because it helps them breathe. Okay? They like their caffeine. And that's why they don't even realize it, but it's actually helping their airway. Okay, corticosteroids. We talked about these in the context of inflammation. Well, we said that both asthma and chronic bronchitis deals with inflammation of the airway, so it only makes sense that we would use it to reduce airway inflammation and the swelling in that airway. And it does it primarily by inhibiting the breakdown of epinephrine. Okay, so let me go back and remind you the fight or flight response. What's the primary hormone that's released when we feel threatened? Adrenaline, or the other word for that is epinephrine, okay? One of the things it does is it dilates that person's airway so they got plenty of oxygen to fight or to flight. So as long as you got that epinephrine in your bloodstream, then you bronchodilate to improve airflow. Well, corticosteroids limit how quickly our body can break that epinephrine down. So all of a sudden you get prolonged bronchodilation from the epinephrine that is secreted. There are inhaled corticosteroids, there's oral and IV form. As the client improves, we should taper them off because our body makes its own corticosteroids with, let's see, are we at Tonqual? Tonqual? What part of our body makes its own corticosteroids?
Okay.
Did you hear that, Mr. Gray?
Uh-uh.
Adrenal glands.
Adrenal glands. So what happens when we give somebody supplemental corticosteroids, we suppress the adrenal glands function. So we can't abruptly stop their medication, their corticosteroid, without their adrenal glands being surprised by it. Well, I didn't think I was needed. I've not been working for a while. And, I've just been waiting for an opportunity, but, you gotta give me a heads up. I gotta get back from the Bahamas before I can do my job, okay? So we have to taper those medicines. That's why if you've ever taken like a Medrol dose pack, you take the most during the first few days and then gradually tapers with each day that you take it. So those are some examples. So the prednisone is oral form primarily, both tablet and liquid. This is inhaled, or it can be a nasal spray. And then these other two are IV forms or parenteral forms. Side effects. Although corticosteroids are wonderful, they have a lot of side effects. The ones that you've already learned about in several different contexts is it changes the person's blood sugar, it can generate an ulcer, and it interferes with healing of the wounds. Okay? Another one that, for some reason, I think I've overlooked it there, I didn't put it on there, is it compromises their immune system, meaning that they can get an infection and not show it up. It doesn't allow us to see those typical signs and symptoms early. And so their infection can be pretty pronounced before we even realize that they've taken one on. Okay? Will it still show in the white blood cell counts? Yes. Yeah. Good one. Question?
Medication or the examples, the two first ones?
Okay, so prednisone, the question was what forms? Prednisone is typically oral. There's both tablet and liquid for little guys. And then the budesonide is a nasal spray primarily, but there is a inhaler form as well. And then these are both parenteral forms. Okay. So obviously the oral thrush is more common when you're using an inhaled version than an IV version. Okay. I think that's a good stopping place. We're about halfway through the minute. We'll come back and look at those others. And if you can give me 7 minutes, let's do it in 7 minutes, all right?